Vancomycin Flushing Syndrome, formerly known as Redman syndrome, is an infusion-related reaction that occurs when vancomycin is administered too rapidly into the vein. Note that VFS is not an allergy because in a true allergic reaction, the immune system is involved. By recognizing a substance as foreign, the body would then produce IgE antibodies specific to that substance. Upon re-exposure, those antibodies trigger mast cells and basophils to release histamine and other mediators, leading to the presentation of an allergic reaction. In VFS, vancomycin directly causes mast cells and basophils to release histamine without any involvement of IgE or prior sensitization. This is called a non-IgE mediated histamine release or anaphylactoid reaction. Let's look at the mechanism in detail. First, rapid infusion, meaning infusing at least 1 gram of vancomycin in less than 1 hour. This leads to a high plasma concentration of vanco. The plasma of vanco directly interact and activate mast cells and basophils, leading to histamine release and other inflammatory substances, which leads to the following signs and symptoms: rash, flushing, and redness on the face, neck, upper torso, hypotension, fevers, back and chest pain, angioedema, or difficulty breathing. Symptoms typically appear within 4 to 10 minutes after starting the first intravenous dose of vancomycin, although this reaction can develop later during the infusion or up to 7 days after its completion, and even with subsequent doses. Aside from infusing the drug too fast, there are other risk factors that increases the probability of this reaction occurring. So first, dose exposure, higher doses, so usually above 15 milligrams per kilogram, children and elderly, and if the patient had a prior reaction. To manage these patients, we follow a systematic approach. First, the infusion should be stopped immediately. Determine the severity of the reaction. If it's mild, the patient will present with chills, flushing, and pruritus. These can be managed with histamine 1 blockers like diphenhydramine and histamine 2 blockers like famotidine. Histamine 2 receptors play a role in acid production, but these receptors are also found on blood vessels. And when histamine binds to it, it leads to flushing. That's why we use the histamine 2 blockers. I actually have a video covering H2 blockers. I'll include the link above. Mild cases usually resolve within 30 minutes and the vanco can be restarted once the patient is more stable and signs and symptoms subside. The vanco should be started at a slower rate, so at least 1 gram per hour. Moderate to severe cases present as rash, tachycardia, chest pain, back pain, muscle spasms, weakness, and angioedema. Patients should receive H1 and H2 blockers, plus or minus epinephrine, depending on if the patient is presenting with possible anaphylaxis symptoms like hypotension, difficulty breathing, wheezing, and hives. The infusion can be restarted at a much slower rate, so over 4 hours. If vancomycin must be continued, patients should be pre-medicated with H1 and H2 blockers intravenously about 30 minutes before each dose. If vancomycin is not a must or a requirement, then you could try an alternative antibiotic. And that will be the end of this video. If you learned at least one thing, please hit the like button, subscribe, and leave any comment down below.